Welcome to the Athlete's First Performance Podcast, where two performance-minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals.
All right, episode 7 of the Athlete's First Performance Podcast. Today we're going to be talking about hip pain, particularly femoroacetabular impingement. Hey, James, what's going on?
Not too much. Everything's going well. Excited to get into this topic. I know this is something that I see quite a bit up here in the clinic and dealing with it a little bit myself. So it's always fun diving into some treatment for yourself.
Yeah, I assume being up north, you work with a lot more hockey players, and I guess I will learn that too. So you probably see it quite a bit.
Yeah. How's everything going with you?
Pretty good. Adjusting to this, it's been crazy. We've had 99-degree weather. I feel like I'm back in South Carolina. Humidity's not bad though, so it's not terrible. But I thought we were gonna have a little better summers than we do.
Yeah, it'll cool down a little bit. It won't be high 90s every day.
Yeah, lack of humidity is a big deal for me, so it's all good. But all right, yeah. So kind of give you the lay of the land. So we're gonna break down the different diagnoses that you'll see with hip and groin pain, and then we'll sort of narrow down into FAI, looking at examination and treatment. So James, do you want to go ahead and get started just defining some of the different possible diagnoses that you could see with hip and groin pain?
Yeah, so we'll start with the Doha Agreement on terminology and definitions in groin pain with athletes. So they divided this into 3 different groups or 3 main categories. The first one was the clinical entities for groin pain. So that you can think of this as more of like adductor, iliopsoas, or inguinal related groin pain. And then the second one was hip related groin pain, which is what we're going to be focusing on today. And then other causes of groin pain in athletes, which could be avascular necrosis, stress fractures, or tumors. And then they further broke down the hip related pain into, again, 3 different categories. And these are the most common hip conditions in young and middle-aged active adults presenting with hip pain. So the first one is femoroacetabular impingement syndrome, or FAI syndrome, acetabular dysplasia. And then the third one would be other conditions without a distinct bony morphology. So that could be considered labral, chondral, and/or ligamentous teres conditions. And this third group is oftentimes found in the first 2 groups. And so we know that there's many hip-related conditions that have labral and chondral conditions that coexist with FAI syndrome and/or hip instability. So Josh, do you want to give us the formal definition for FAI syndrome?
Yeah, so according to the Warwick Agreement, their consensus was that FAI syndrome is a motion-related clinical disorder of the hip with a triad of symptoms, clinical signs, and imaging findings. It represents symptomatic premature contact between the proximal femur and the acetabulum. And I think that's important. So there has to be, what they're saying is there has to be 3 different findings to officially diagnose FAI. And honestly, for me, and we'll talk about this, 2 are the most important, particularly the conservative treatment. And then the last one is going to be something that, you may find if imaging is necessary, if they don't get better, that could be, helped by some sort of surgery. So the 3 different clinical findings, they have to have symptoms of hip pain, clicking, catching, stiffness, or giving way. The other thing, you'll have clinical signs consistent with FAI syndrome, including restricted range of motion or a positive impingement test. And then the last one that, like I said, is a little bit less important in the beginning stages is the radiological findings of a cam or pincer morphology, typically seen on a radiograph. I guess, James, you can go ahead and define cam and pincer morphology and how it may or may not relate to FAI.
Yeah, so cam morphology, simply put, is a non-spherical femoral head. So there's been a gradual increase throughout the skeletal growth starting at age 12, or gradual increase in bony growth starting at age 12. And we know that the extent of athletic activity throughout the growth period may increase risk of a CAM morphology. So they call this an acquired phenomenon and highly influenced by exercise-related loads applied to the hip. So we can think of this as like baseball players or young throwers. So young adolescent kids that begin throwing at a younger age develop that glenohumeral retroversion, and same type of thing develops with the hip. So kids that are involved in sports such as hockey, soccer, football, and lacrosse, where they're constantly cutting, pivoting, and loading their hip, may develop that bony growth of the femoral head. And we know that's more common in males, and there's a higher prevalence in athletes compared to non-athletes, just like we said, with the loading starting at that younger age. And there's various studies that show there's no significant association between a CAM deformity and hip symptoms. And then pincer deformity is considered an overcoverage of the acetabulum relative to the femoral head. And in terms of the literature and the research, there's little difference between male and female rates with this. And then oftentimes there's a combined CAM and pincer deformity in the hip. So it's usually not one or the other. It's usually a combination of the both, or both of them.
Yeah, and one point too to make about the CAM morphology, and pincer morphology follows this too, is that but there was a study done by a systematic review by Dickinson et al. And it said the prevalence of CAM morphology in athletes can range from 48 to 75%. And obviously we know that 48 to 75% of athletes aren't dealing with FAI. So most likely that would be a incidental finding. And the majority of people that have either CAM or pincer morphology are not going to have symptoms of FAI. So let's go ahead and get into the examination portion. We're going to sort of break down an article that was written by Mike Reiman and Christian Thorborg in IJSPT back in 2014. It's called Clinical Examination and Physical Assessment of Hip Joint Related Pain in Athletes. And it's a clinical commentary. They just provide a really nice systematic way of funneling down the exam to the point where you are getting an idea of one of the possible diagnoses of intra-articular hip pain. And the primary ones are going to be FAI, labral tear, chondral injuries, and synovitis. So they start with just generally like anyone would, a history. Then they do observation or just a big picture assessment. Then they go into triage and screening for like red flags, and then other related areas like the lumbar spine or the pelvis. And then they move on to sensitive tests and then into specific tests, and provide a little bit of a general overview of some treatment. So James, in the subjective history, particularly dealing with some of the athletes that you see up there that are, like hockey players, but you could also think of this in the form of like a power lifter or something like that. What are you looking for outside of the normal history questions that you would ask? What are you looking for in patients that may present with FAI?
So we'll start with just like how long they've been dealing with this. A lot of times it could be something that's been chronic or developing over a long period of time, 6 months to a year. And they've just been like, say for a hockey player, they've had nagging hip pain for a long time and they've just kind of toughed it out throughout the season. And now it's the off season, they're trying to get it fixed. Or it could be someone that was just squatting at the gym. They were squatting heavy loads, or they're going through a squat cycle, and all of a sudden they start to feel some pinching or stiffness in the front of their hip. So understanding like how long it's been going on and what sports they've been in, or what activities that have led to the pain or the discomfort in their hip. And then another thing is just managing the loads. So like I was saying, for myself, I know last winter we were going through a squat cycle where we were just squatting heavy for 2 months and just gradually increasing loads. And by the time that we were done with it, I was getting a lot of stiffness and soreness in my hip. So managing appropriate loading is something that's super important with the hip. And then just understanding what activities or what motions bother it. So with running and skating, there's different biomechanics that could lead to pain in the hip versus just things like squatting.
Yeah, no, that does answer the question. Just like with any injury to me that isn't a result of trauma, you need to look for any sort of activity changes, or really just activities that they perform that may aggravate it. But I like to get an idea of, did their training change? Did they increase their volume? Did they add a new movement? Because clearly something's going on to where their hip's not tolerating whatever movement that's aggravating. So that's a good idea to see if that's new, or you increase the volume or the intensity. The only other thing I would add is just looking at their age. There's a variety of hip disorders that can occur that will occur in certain age groups. So just for some of these interarticular issues like FAI, and just like you said before, that CAM morphology occurs during those growth spurt times. So if you're having someone that is coming in that's younger with what looks like FAI or just hip and groin pain, you could be, if they're anywhere 12 years old or less, you could be looking at something like a leg calf Perth's disease or a skiffy, as opposed to if you're getting someone that's a little bit more active and a little bit older, that's when you may start to see some of the interarticular pathologies like FAI or labral tear. And then if you're getting, beyond that into the 50s, 60s and beyond, and I'm sure there's specific numbers out there for this, that you may be looking at hip OA. And not that those can't be related to each other, but using the age kind of will give you a little bit of a direction into the diagnosis beforehand. But no, that was all good. I think one of my biggest questions, like I said, is getting an idea of what's changed in their day-to-day. But so if we move on into just general observation, there's a couple things that you can look at that may help you differentially diagnose between a lumbar issue versus a hip or hip and lumbar issue. And I'll kind of dive into all three, though one's going to be seen once you get to the motion assessment of the exam. But they listed three things in the paper that will increase your chances of possibly having the FAI if you come in with those symptoms. So one being a limp. If someone's limping, obviously they've said that they have hip or groin pain. They are 7 times more likely to have a hip issue over a lumbar spine issue. Them having groin pain gives them 7 times more likely chance for either hip or hip and lumbar over just lumbar. So groin pain will mean that the hip has a good chance of being involved. Not to say that other areas can't be involved, but the hip is going to be part of it. And then with that motion assessment, limited internal rotation has a 14 times more likely chance for hip or hip and lumbar over just lumbar. Another thing with the groin pain, it's highly sensitive. So if they have a lack of groin pain, that can help rule out an intra-articular issue. So because the presence of groin pain is highly sensitive, up to 96 to 100%, if they don't have it, it can be pretty confidently ruled out that it's not an intra-articular issue. And then you also may see sharp pain with mechanical symptoms. That is a pretty high sensitivity also. So with the lack of those two things, you're probably not looking at hip pain. Is there anything else that you would look at, whether it's just observation of them walking in or how they sit or anything like that?
Yeah, a lot of times I'll watch how they're sitting. Sometimes I don't get a full glimpse of their walking if I'm in front of them or things like that. But a lot of times they'll often unload their hip, or they'll lean back in their chair just to get out of that deep flexion angle. So those are pretty easy cues to understand, okay, is this a sitting problem? Is this a closing pattern problem? Because a lot of times they'll alter their positions. A lot of things that I also like to ask are like, okay, how are you with putting your shoes and socks on? Because they have to get into that favorite position. They have to be able to cross their legs. So oftentimes people will complain, especially some older folks will have difficulty being able to cross their legs, put their shoes and socks on, or just simple things like that.
Yeah, it's actually in that paper too. They break it down pretty interestingly, and you may see it honestly may give you an idea, at least of what they're capable of by activity that they say they can't do. So they wrote down the hip range of motion required for certain activities. So I'll just basically read through this just for just as like, having the objective measurement. So gait on level surfaces requires only 30 to 45 degrees of hip flexion. Going up and down stairs requires 45 to 66 degrees of hip flexion. Sitting in a chair of an average seat height requires 112 degrees. Putting on socks requires 120 degrees of flexion and 20 degrees of abduction, and 20 degrees of external rotation. So you can kind of get an idea. I mean, if someone's not having an issue with some of those easier tasks, like going up and down stairs or just walking on level surfaces, but then they start to have issues with, they say putting on my socks is hard or prolonged sitting is hard, then that's going to point you in that direction also.
And I think we had this conversation. These are pretty good clinical pearls in terms of just the quick subjective and objective measures that you can get in the clinic. And I think I talked to you about this. I had a patient probably a few months ago that came in with diagnosed of lumbar spine pain, or he had some type of MRI of his lower back with radicular pain. He saw several different doctors, and I saw him come in. I almost thought he needed like a cane or a walker because he could not walk. So he came in with a limp, significant groin pain, and very significant mechanical hip pain with just like 20 degrees of hip internal external rotation. Couldn't handle that, couldn't handle more than like 70 degrees of hip flexion. I was like, man, we need to send you back to the doctor. There's something more going on here. And later to find out that he's an alcoholic, and sent him back for x-ray, and I think he had a CT scan. He had avascular necrosis. So I read this paper not too long before seeing this patient. So those clinical pearls definitely helped me out there.
Yeah, and it's not, and it's funny because sometimes when someone comes like that, I remember you told me that, and I was going to ask you about it. It's everything that you just said shouts hip. Obviously, hearing that in this environment versus seeing it in the clinic can change things. And sometimes, when you hear previous providers say they think it's this versus that, you may get a little biased towards what they said it was. But yeah, just listen to what they're saying. And I mean, obviously some motion testing would be required to see if they can handle or not rotation, like you said, or hip flexion. But just them saying that, for example, sitting in a chair would be difficult because it's more than 7 degrees of flexion, like groin pain, mechanical symptoms, limping, like the shouts hip to me.
Yeah.
So that's awesome. It's a pretty good little case study.
His biggest thing was like, I can't walk because he's limping and it hurts, and he couldn't go upstairs. Like he could not load I think it was his right leg. He could not load his right leg to push up going upstairs. I was like, okay, maybe your back is a little bit sore, but that's not the true cause of what's going on. It's definitely your hip. So yeah. He ended up getting a hip replacement not too long afterwards.
Hey, I mean, it's a good find.
All right. So we've gone through the subjective interview, then we've gone through a little bit of observation. Where do we go next with the triage and screening process, Josh?
Yeah, so just like anything, you're going to start to look at the serious pathology, the things that may indicate that PT is not appropriate, and they need to be sent somewhere else, whether that's urgently or not. With any condition, there's the most common and major red flags, such as history of trauma, fever, unexplained weight loss, burning with urination, night pain, and prolonged corticosteroid use. Now, all those may not apply to like globally to everything, but they're just some of the common ones with hip and groin pain. Two, I guess, interesting things that particularly relate to the hip. You want to look at the previous history of cancer, because particularly prostate cancer in men or breast cancer in women, because those cancers can be associated with metastases to the hip joint. So obviously if that's something that you'd like to get a good history on, if things aren't lining up the way that they would typically sound for hip or groin pain, like a musculoskeletal condition. Now the other piece of this could be not necessarily one traumatic incident, but maybe a repetitive trauma that could result in a stress fracture. or just a regular fracture if it's gone that far, but typically a stress fracture. And this can be seen in runners, things like that, long distance runners. So there's a few tests that you can do that are highly sensitive. So you can rule out that issue if they are negative. One being the patellar pubic percussion test. And this paper will give you sort of the rundown of how to do these tests, but I'll briefly describe it. So essentially you have a stethoscope, and the stethoscope is on top of the pubic tubercle on the involved side. And then you will tap on the ipsilateral patella. And if if it's a diminished percussion noted on the side of pain, that would be a positive result. If not, then it'd be negative. I don't know. You can chime in on this, James. I don't think I've ever used this, and not that I've, and obviously to have people that come in with a stress fracture isn't, every day. So it may just not have had the chance, but I don't know. There's a lot of stuff in between the stethoscope and the pubic tubercle. I guess you can compare it side to side and just look at that. But the placement on that could be tough. And then real quick, the other one that you can do would be a fulcrum test. So the athlete will be sitting, and you're going to place your forearm under the involved thigh and apply a downward pressure at the proximal knee and looking to reproduce pain. So if those are negative, you can effectively rule out a stress fracture or fracture, but also keeping in mind that the history should coincide with that. So no major trauma or no incidence of maybe an example of a runner increasing volume or something like that. Do you ever use, or have you ever had to use any of those, particularly the patellar pubic percussion test?
No, I remember learning about it in school, but I've never used either of those tests in clinical practice. I don't know if it's just the population that I'm used to treating, but I have not come across any of that, which is good because that's not something that you want to be dealing with. Doesn't seem like a fun diagnosis or fun treatment progression, but it is out there with, like you said, those endurance runners, maybe like gymnasts or military population where they're just doing long, repetitive rucking or running or jumping, landing things.
Yeah, when I was in my last rotation at PT school, it was Fort Jackson in Columbia, and we were working with basic training and advanced training soldiers, and particularly the basic training. These are kids that are coming out of high school, maybe not. And honestly, it seemed like the majority didn't have a really strong background in exercising. I'm sure they trained for basic, but just total history. And for them, anyone that said they had hip pain, they were immediately put on crutches because they're afraid of that femoral neck stress fracture. So yeah, obviously something you don't want to see, but definitely something that you should, in an ideal situation, be able to catch because of the large ramifications down the road if a stress fracture is missed. And this is a whole different podcast, but there are kind of higher level or higher level or hip stress fractures that are a little bit more worrisome than others, and then just stress fractures throughout the lower limb, but something to keep an eye on. The other thing that I'll let you kind of dive into is differentiating hip pain from either the lumbar spine or the pelvic girdle.
Yeah, I think this paper does a really good job of simplifying everything. I know in school they always say, okay, with anyone that has lower back pain, make sure to check the hip, and then vice versa. So this paper does a really good job of just kind of, like we said, funneling that approach and then using sensitive tests to help screen out and rule out different pathologies. So in terms of the lumbar spine, there's two main categories that they talk about in this paper, like discogenic or radiculopathy, and then facet joint related pain, both which could refer down to the hip. So in terms of discogenic or radiculopathy, they talked about repeated motions. So in your standing or in supine or prones, either loaded or unloaded, going through repetitive flexion and repetitive extension to see which movements centralize and or which movements peripheralize pain. And then they also looked at the straight leg test. So we know laying down on your back, passively raising the leg into flexion, and then tensioning the nerve with either adduction, internal rotation of the hip, and or dorsiflexion of the ankle. So those are two sensitive tests that can help rule out discogenic pain. And some things that I also use are just like your general lower quarter screen, like dermatomes, myotomes, reflexes. That's always important to help rule in or rule out different radiculopathy or discogenic pain. And then when it comes to facet joint related pain, this is another good test, the extension rotation test. They did this in sitting, but you can also do it in standing just to help load that facet joint a little bit more to see if that reproduces their familiar pain. And then they call this pelvic girdle pain, but this is more like SI joint pain. So they use the thigh thrust test, where you're pretty much laying down on your back and you are bringing the hip up into flexion and adduction and then creating like a shearing force down through their SI joint. Anything else that you use there to help rule in or rule out?
I mean, obviously in that subjective portion, if they have symptoms that sound neurogenic, then yeah, I will first certainly will, I'll do the straight leg raise. I may do a slump, repeated motions, and myotones. I really like reflexes. Reflexes to me tell me a lot, but I always ask the patient, just because people, I want symmetrical reflexes. And I always ask the patient, because reflexes can vary so much just day to day. Do they typically kick a lot or not? So if I do the patellar or the Achilles, do they, a lot of people haven't even had their Achilles reflex done, but I always get an idea of like, do you typically kick a lot or no? And then if I see any sort of, and maybe I should do this every time, but if I see any sort of abnormality with the reflexes, I'll also check for clonus with a quick ankle reflex. Just, it's easy, it's not hard to do. So, but otherwise, no, I think that's maybe if they're on the table, I may do it's just some P to A's to the lumbar spine or SI joint or something like that. But no, I feel like, again, if it's like a hip, especially like an FAI, is pretty particular. So I think you almost get an intuition into if the lumbar spine's related or not. But yeah, some of these tests are super easy and super quick to do. So if they're not too sensitive, then I would for sure add them into the exam. And the other thing that you can look at is, and we talked about a little bit with the CAM and pincer morphology, is diagnostic imaging. This paper has pretty good descriptions on all the possible imaging that you could go through. I think for probably most common and for what we're talking about, FAI, an X-ray is enough, and there's different views and there's different measurements as far as angles and things like that will give you an insight into possible CAM or pincer morphology. We'll let you guys read into that. The paper describes it way better than we will ever describe it. But yeah, those are things that you can all look at. Obviously, radiograph can show signs of stress fracture or fracture. So just things to be aware of.
Okay, so we've screened for serious pathology. We screened for the lumbar spine and pelvic girdle pain. What are we using to screen the hip in particular?
Typically, and what you should do is start with sensitive tests, just like we've kind of been talking about. There's not the main test, which is a great test, and it's good that there's kind of only one because it takes out a lot of confusion, is the flexion, adduction, internal rotation test, or the fader test. So the patient's in supine and you're essentially bringing the hip into flexion, adduction, internal rotation, and looking for reproduction of pain. It has a really high sensitivity, not a great specificity. So you're looking for reproduction of symptoms. It doesn't necessarily mean, if it's positive, that you are dealing with intra-articular pathology, but if it's negative, you can confidently rule it out. Do you have any other tests? I mean, that's the main one that I've done and read about.
Yeah, and I think that's important because in school, from my understanding of what we learned in school, if someone had a positive fader, you're like, okay, they're done. They have a hip impingement, they have a labral tear, can't do anything with them. So I think it's important for younger clinicians to understand you're not ruling anything, but if they have a negative fader test, they probably don't have intra-articular hip pain, or they don't have an intra-articular hip problem. So it's more of, like you said, that just broad test to determine, okay, if it's negative, just rule it out. If it's positive, we need to keep on digging deeper and figure out what's actually going on. But in terms of just special tests for the hip, I'll go through like a scour test to see what positions, like if it's more of flexion or if it's more of adduction that recreates their pain. Then also do a Faber test. So I like to see, that's just a good side-to-side test that I like to see. Okay, is it limited range of motion? Is it painful? Is it both? Just to see what those combined motions look like for that particular hip. And then also going through just like mobility tests, like a Thomas test to determine, okay, is it more of like a deeper hip flexor limitation? Is it a lateral chain limitation, or is it more like a quad limitation that we need to start working on either with exercise, hands-on work, or just individual stretching?
Yeah, I definitely like to run through some of those tests primarily for just pain provocation, more for my mind over like this means that they have XYZ. But yeah, motion tests are really good, especially if I have someone that comes in who has pain with deeper squatting. And in a, I guess, an obvious sense, someone who's like a powerlifter who's going deep, or even just someone that comes in with pain with sitting in a chair or like moving in that transition. So I'll have them in supine and I'll bring up their hip into straight plane flexion. And then I'll play around with internal rotation, external rotation, and just get an idea of like, oh, well, maybe we can just change their stance a little bit, and at least in the short term, improve symptoms. So that'd be something that in addition to what you're doing, and I know you talk about range of motion. And one of the other things, and this is more for hip OA, but I guess you could say FAI too, is I see a pretty strong lack of internal rotation. Where they and not seeing them make up for that total arc and external rotation. And it feels like a really bony block, sometimes painful, sometimes not. And then and I'm sure you probably saw in that guy with AVN, they may not have it on the other side. If they have it on the other side and no pain on the other side, I'm not as concerned with it, unless what they're trying to do requires that movement. But yeah, motion testing's big, strength testing's big. I guess we haven't gotten too much into strength testing. Do you want to start there and let me know what you look at, whether it's on the table or whether it's a functional movement, out in the clinic?
Yeah, before we get into that, another thing, so in terms of motion testing, I don't know how you like to do it, but I'll test them either in one 90-90 position. So either sitting in 90-90 or supine, bring their hip into 90, checking internal external rotation. And then I'll also get them prone with the hip and extension at 0, and then measuring internal external rotation to see if there's any differences. So if they're lacking hip internal rotation in that 90-90 position and at 0 degrees of extension and prone, then I'm thinking, okay, there might be some bony morphology. They might have retroverted hips. And I know there's specific testing to determine retroversion versus antroversion, or anteversion. So I usually like to do that to help determine what we're working with. And like you said, that end feel is super important. So if you're hitting a bony block with hip internal rotation, I mean, you can still do some hands-on stuff, but you don't want to force them into heavy loaded hip internal rotation in terms of trying to get more range of motion. You're just going to aggravate their hip. So helping determine, is it more of like a capsular end feel, like a bony end feel, or whatever you're looking at. Just don't force people into bony end feels.
I think that's a good point. I would say on the norm, look at hip rotation in that 90-90 position in supine. But I will add that occasionally, particularly if someone doesn't feel limited in supine, I don't typically look at it too much in prone. But if I have someone in prone and I'm looking at like quad length or something like that, sometimes I'll check rectus femoris length there too by checking quad length plus hip extension. I'll go ahead and rotate and just to see where they're at. But if I don't feel a bony block in either position, then I'm all game for getting motion back. If I feel a bony block kind of in any position, I won't aggressively attempt to get it. I may do some, and we can get into this with treatment, I may do some long axis distraction or something because it feels good, but I'm not trying to have them crank into internal rotation. So yeah, is there anything else before we move into strength?
that pretty much covers everything. So yeah, I just want to mention that 90-90 and that prone. It's just another good thing to look at.
Yeah, it's
As a
great tip.
rotation. But to go back on what you're talking about with the strength testing, I've never had access to a handheld dynamometer. So I think that would be the gold standard in terms of testing hip strength, just hip girdle strength in general, flexion, extension, adduction, abduction. So I think that's all super important. But in terms of functional tests, I'll get them into like an overhead squat just to check overall mobility, a double leg squat with arms down, a single leg squat to a box, or even like a 8-inch heel tap, just looking at how well they control their lower limb and their trunk, because we know that biomechanics in terms of getting into hip adduction and internal rotation in a single leg squat or single leg stance can lead to more of that anterior hip or groin pain. So those are a lot of the things that I like to look at. Oftentimes I'm not doing like a wide balance test the first day, but as they keep on progressing, if they're a more athletic patient or if they're getting back to heavier things, I'll always check like a wide balance test and check single leg strength, stability, and mobility.
I think that's good. I think the process, and just I don't know, big picture, if to do those things, that's like the very first thing that I do. Mm-hmm. So even if I'm doing, like, I'll also add that lumbar screen with repeated motions and such and standing. And then, yeah, it depends on the person, but you know, if I have someone who's a little bit inactive, I'm really just going to look at maybe a squat or a sit to stand. And I can play around with the table height and see where that is. And it's a good objective measure because I can measure the height of the table and see if we can get it lower as they get better. But then if it's athlete or something higher level, I'll dig into some of that stuff, particularly focusing on their aggravating activity. And you can, and like I said, you can play around with things right then and maybe pick up a little confidence to improve their confidence in you if you can change their pain right away.
Yeah.
So that's kind of cool.
Exactly. Like what you're talking about with the squatting example, that's great. Just to be able to check their normal path of their hip. So it's just like scaption of the shoulder. Some people don't do well with straight plane flexion. They do better with scaption. A lot of people do better with more of that. I think I read in paper hiption. So not straight plane hip flexion, more of a little bit more abducted axial rotation position. So you can change someone's squat by just, again, playing with their hip width or their foot width and then their rotation. And that can clear up 10, 15 degrees of their squat pretty quickly without even touching them.
You have to break out of this mold of like, you have to move. You should be able to move this much in this direction, because just with the different morphologies or makeups of our pelvis, or in the case of the shoulder, everyone's different. So you can't force somebody into a movement they're not comfortable with, because that's probably what they've been doing, which is what's created their symptoms in the first place. So getting a good understanding of the biomechanics of the possibilities, and you don't have to do it. I mean, like I said, you could do it in supine, just move their leg around and figure out what's comfortable, and then see if that can transfer into a loaded position into a squat. So yeah, it's like, I think that's big. I mean, you could be just running in circles if you don't think about that.
Is there anything else that you like to look at in terms of strength or functional testing for the hip?
No, I like to use, I mean, obviously I kind of keep it simple. So if I'm, the functional tests are good, I'll put them on the table, and get an idea of what they can, basically how willing are the muscles to contract. So to see if there's pain involved or something like that. If there's pain involved, typically they're not going to be as strong. And that's a bit of something that's hard to delineate. I mean, if you know that you are able to test something, they don't have pain with it and it's just weak, well, then that's something to address. And you can kind of compare that either from the functional movement that you saw, or you can have them do a different movement afterwards and see if it's different. I like your route of doing functional first, because then you don't bias yourself into a particular muscle being weak. But yeah, I'll check extensors, abductors, adductors, and flexors. I'll check the external, internal rotators too. Those are kind of always weak, so I don't get too dialed in. But just comparing side to side, seeing if they hurt, just because it's a possibly if doing something loaded or one of those functional tests are still uncomfortable, I'm going to start with something on the table anyway. So get an idea just to direct my initial treatment.
Yeah. Do you check any soft tissue? Like, do you assess
Like
that at all?
like tenderness or length?
Yeah, like tenderness, just like stiffness. Because
Yeah.
we know,
Well,
yeah,
go ahead.
yeah,
Go
because we
ahead.
know that a lot of people with hip pain or anterior groin pain have a lot of, they call it hip flexor tightness. They have a lot of tightness in the front of their hip. Some people call it tendonitis or tendinopathy, just like irritation in the front of their hip. Same thing with the adductors and quads. So do you ever check any of that?
Because I sort of, when I'm trying to formulate my treatment, like in the evaluation or even just a plan of care, because I like to just obviously describe what I think we're going to do as we go. I try to I think of it as different buckets. So you have sort of your mobility bucket, and within that you have joint and soft tissue. Then you have pain, which or I guess you could say you have strength, which could have underlying pain implications or just weakness. And then that gives me an idea of where I'm at. And then you have your activity modification, things like that. But to me, it's typically a strength or mobility issue. And then as you pick up those things, you move into graded exposure into what they're doing, what they need to do, which is sort of how I treat everything. So yeah, muscle length and tenderness is, I put a, I rely on that a lot. So whether it's a Thomas test, whether it's a Faber or Eli's test, or just quad length test, hamstring, I look at all that. I always try to palpate, because if I think of it as I can push on something and reproduce pain, whether it's referred or not, and it's their pain, it's like, well, I should probably treat that. With whatever means you know how to treat, you're essentially just trying to most likely just changing the pain pressure threshold. So I'll do, without getting too much into treatment, I'll always check the hip flexors. The only thing is that if you push on anybody's hip flexors, they're probably sore. So again, it's just comparing side to side and seeing if it reproduces their pain.
No, I think that's important, especially like you're saying, if you can push on their familiar pain, that helps get them to buy in. I was like, okay, you found what's actually going on in their mind, and being able to work on that, however you know how, is something that will just get more patient buy-in, and they'll have more faith in what you're doing.
Yeah, and that's like, and I don't know where I think it was Meekins, and Adam Meekins. We talked about this in the shoulder podcast. Like, he breaks it down as like, but one of the things that he breaks down is like touching. Like, if you don't, even if you just touch their hip, which you're gonna do, they're gonna have confidence in you. But if you can actually reproduce their pain, or like we said, change their pain, ideally in a positive way, they're like, oh, okay, this guy knows what he's doing, I'll buy it. And it'll be like, oh, my pain isn't, I can change it right there. It's not going to be stuck with me forever. So do you think we're good on the exam? Because I want to get into some treatment before it gets too long.
Yeah, I think that's good. And it covered a lot of the basics. And I would encourage everyone to look at that paper. Even if you're not seeing a lot of hips, it's just a good way to think about your general exam overall, just funneling your approach and making it more specific to what you're doing.
Yeah, Mike Reiman seems, and obviously it was him and Christian Thorborg, but everything I read of Mike Reiman is like super simple, makes total sense, and gives you a great plan to attack. And this stuff can be taken to any possible diagnosis.
Yeah, and we'll link that paper in the show notes and on our website, so check that out.
Yeah, so if we get into treatment, I don't know how you think about it, but I kind of said, like, I think about it in terms of mobility, strength, and then graded exposure. How do you think about treating FAI?
Yeah, no, I think it's really good. I've been trying to develop more principles instead of just methods. So I'll let you expand on your principles a little bit more, but I agree with that. So getting mobility, so getting them to have specific movement variability, and then movement coordination. So if in my lens, I look at it as like SFMA. So getting appropriate mobility in whatever you're looking at, and then movement coordination would be more of like FMS, or just functional movement patterns, like being able to control a single leg squat or an overhead squat, just being able to control that. And then building up strength, like rate of force development, more like force velocity curve, and then getting into capacity, so energy system development and things like that. And then you can get into, like you were talking about, like load management or progressive loading, and then patient, how they think about things. So patient values. So those are the 6 principles that I try to look at. And I've been trying to develop my own principles over the last couple months, but that's how I like to look at things.
Yeah, I think that's great, because any people will fall anywhere along that, because that's basically a spectrum. And people will fall anywhere on that spectrum. Some people may not need to get to energy system development. It just depends on what their goals are. Some people may be closer to that than they are low level. So yeah, I guess I haven't officially named my principles, but when I think of how I'm going to develop a plan, which is then dictates how I'm going to do an evaluation. This is basically how a lot of these funnels say is I always try to get an idea when I'm doing the eval after I finish and have a decent idea of what we're going to work on. I educate the patient. And one of the things with FAI is I may educate them for a little while to try to sit in a higher chair or try to avoid certain activities just to calm things down if it's highly irritable. If it's not, then I may say, all right, well, let's go ahead and start working into some of those positions, which would be that graded exposure thing. Then I feel like I treat everything impairment based, which I guess is what you should do, particularly FAI. And like, I don't really worry about what the image would say, because there's nothing I can do about that. So I might as well just treat conservatively. And that's going to be with mobility, strength. If pain is a big piece, just in a like low level activities are uncomfortable, as opposed to someone saying, oh, it's only when I overhead squat with X amount of weight. So if pain is a primary factor, then yeah, I'll do whatever, whether it's soft tissue or people love long axis distraction. I don't know. I'll throw that in there for 5 minutes just so that I can give them some relief, because that'll help buy-in. And then when I say graded exposure, it's essentially kind of the back end of your spectrum. So getting them up into the positions they're not comfortable with, gradually loading them. And then if their sport requires high velocity or high forces in those positions that are uncomfortable, then I'll gradually build them into that. So then that'd be like hockey. So it just sort of depends where they fall on the spectrum. But yeah, I do education, then my buckets will be mobility, strength, and pain. And I'll try to change those in a positive way. And then graded exposure, so they need to get back to. Those things will overlap. Some people may not need to go as far, or some people may be starting a little bit higher level. And I just, if it's an exercise or a movement, I just break down the movement as low as I can. And someone will be like, oh, that's super easy. I'm like, okay, well, let's crank it up a notch, just to find their baseline and then go from there.
Yeah. So to keep on making this more specific, because I think this can be a podcast in itself, just the overall guiding principles. Maybe we could do that one day. But in terms of FAI, yeah, and that'd be a good one. You've already mentioned modifying positions. So not sitting in a low seat, maybe not crossing your legs. Sometimes people have pain laying on their side, so modifying their sleep position. So getting them in supine with pillows underneath their knees. Let's see what else. Maybe just modifying how they're walking. So if people are walking on like unlevel surfaces, or if they're doing a lot of walking on a sidewalk or a street that's a little bit slanted, making sure that, okay, you walk one way and then flip around the other way, just so you're not constantly loading that same side. With athletes, so let's talk about like let's talk soccer. So if a soccer player is having a lot of hip pain with cutting, they're getting sharp anterior hip or groin pain with cutting. Maybe they can keep up doing their light footwork or individual drills and focus on more of straight line running if they're able to do that, and then back off on more of the high velocity cutting and change of direction. So just being able to modify in terms of what the patient's or the athlete's doing in their sport or their practice. And then you already mentioned a little bit of how you treat pain. So what are some other things that you do outside of long axis distraction
for pain?
Yeah.
Like soft tissue work, I may do whatever is considered a hip flexor release, but it's just essentially again changing the pain pressure threshold of whatever's tender. And I only really attack the things that are reproductive of their pain. So if I'm pushing around on the glutes or the piriformis or whatever I'm poking at that point, just because it's kind of hard to tell. If it's tender, but it's not really reproducing their pain, I don't really worry about it. So again, if I push on something that causes pain, I'll do some sort of soft tissue work or some sort of glide or something just to change that. And then I'll get them up and move. In the general sense though, if they've been having it for a long time, the way I'll treat pain is again, graded exposure, and just gradually expose them, improve the joint's tolerance to whatever it is. So nothing special. There's no magic bullet. And sometimes immobilization works great for one and soft tissue works great for the other, and none of them work and you do something else.
Mm-hmm. Yeah, I like to teach people. So like I'll do soft tissue work to them in the clinic, 5-10 minutes. Same thing with dry needling. If they are expecting it, or if they've had good relief from it in the past, I'll do dry needling to their lateral hip, their glute, maybe hip flexors. But I'll usually go ahead and teach them how to foam roll. So I know you have some experience body tempering. I've never used that in person, but I'll teach them how to foam roll their quads, their glutes, their adductors, their hip flexors, or even do like a soft tissue release with a tennis ball. And then I'll teach them a lot of like Kelly-Starrett's banded mobilization. So I use that myself quite a bit before doing a lot of squatting or things like that. So I'll just teach them 3 or 4 different band mobilizations depending on what they need.
Yeah, that's a good point. And I forgot to say that. It's just educating the patient on things that they can do to give them some control. I mean, body tempering is something I just kind of think of as reverse foam rolling. Obviously you can't really body temper yourself, and no one has an 80-pound bar laying around. So foam rolling I've been utilizing it more, particularly in the population I'm working with now. Just as like whether it's a warm up, it just changes the way you feel, which can then change the way you move, at least temporarily. So yeah, I think all of those are good for mobility, but also pain.
So do you have any suggestions in terms of exercise? Because that's ultimately what we really want to be focusing most of our time on, is exercise and strengthening and things like that. Do you have any progressions or things that you like to start with? I know it's very different depending on what patient you're working with.
Yeah, I think you'll have a little bit more specific answers for this, but if somebody has, wherever they fall on that typical FAI movement or aggravating movement spectrum. So if they have difficulty with 90 degrees of hip flexion or a 90-degree squat versus an 80-degree squat or something like that, I'll play into that a little bit. So I'll just bump into that threshold that they're comfortable with. And I really like, and I'm fortunate to have now, I have a whole gym to work with. So I like to work with the leg press. So if someone can't get in the deep squat, I have to decide whether it's just the position or it's the load. So if I have them in supine and I can get their knee or their hip all the way up into full flexion, doesn't hurt. I'm like, okay, maybe it's a combination of that and the load. So then I'll put them on a leg press and have them either move into that close to that angle that they're not comfortable with, or I'll drop the weight and have them see if they can basically go as deep as they can and back up. So that's sort of how I would teach the tolerance, and that goes with any activity. If I've looked at like a single leg squat or a single leg step down, and they are moving into a ton of like adduction, internal rotation, well, as they get lower, they're going to add flexion. So that's a fader test. So I'll try to work on controlling that movement, whether it's within the task, or I'll break the task into pieces and then bring them back into it. I know we've talked about, or you've mentioned that you like to, which is sort of counterintuitive to some things, but you like to get away from the bilateral movements and move into the single leg movements. So why don't you describe kind of how you do that and why you do that?
Yeah, so early on, if someone had pain with squatting, I would just teach them how to box squat. So elevating the box above their painful range and working on that. But I found that working on single leg movements, or like a single leg with a kickstand assist, so they're not having to worry about balance, just getting them into that single leg position gives them more the movement variability. So they're not stuck in that bilateral pattern. They can be on one leg and move around a painful position. So if you think about like the shoulder, so if some people have pain with like a barbell overhead press, they might be able to do a dumbbell or kettlebell overhead press a lot better or a lot more symptomatically because they can move around in their comfortable range. So same idea goes with the hip. So if they're having pain with squatting or deadlifting on two legs, you can get them into more of a split stance for a split squat or rear foot elevated split squat, or even like single leg, as long as they can control it well, just to move around into their comfortable positions and not get stuck into that pinching pain in the groin. So that's something that's really, really helped with the athletes that I'm working with.
Yeah, that you're basically increasing the degrees of freedom. So you let them work around, and that barbell, just like a squat where they're maybe going too narrow or something, it locks them into a position. So they can explore the range a little bit more. And it works on control, which is always good.
Yeah. So ultimately the goal is to get them lunging, squatting, deadlifting, and some sort of variation just to help build overall strength and capacity. Some things that I like to do, if someone's really flared up and they can't really handle too much, I'll start with like isometrics. So banded isometrics and supine or side lying with some type of like bridge or external rotation or abduction. Just get that muscle going, get some blood flow into that area and start building a little bit of capacity, but not flaring them up with heavy weight bearing stuff.
Yeah, you can always move them in the opposite of those positions that hurt first. Just like if you're doing someone that has like discogenic pain and you want to do repeated motions, you move into the comfortable positions first and then gradually expose them to the uncomfortable positions. Depends on how sensitive they are. But no, that's really good. And those are going to be added into your program anyway. Because like if I do a whole program of just pushing someone into a deep squat gradually, that's too much volume and they're probably going to get pain. So I may do a little bit of that, but then I'm also going to train the like all planes, not just the one. And then to just in addition to getting them comfortable with loading, just like you said, if you have a hockey player, soccer player, something that requires deep cutting, you're probably going to look at how they're cutting to see if they are dipping pretty low or into higher levels of adduction, internal rotation. And from that last thing we talked about, like getting low is important. And that means that you have a good capacity to control the cut. But if you pull them out of cutting for a little while, and then you have to get them strong, build their capacity, and then give them the ability and tolerance to use that capacity quickly, which is what you need with the cut.
Yeah, definitely. And then in terms of like wrapping this up, again, something that I used to only focus on were like the glutes. So like hip extension and hip like external rotation. I started using a lot more loaded and like eccentric hip flexion and adduction because those are super strong muscles in the hip and you want to get the hip strong in all different planes. So being able to load hip flexion, be able to load hip adduction are super important things that a lot of people I feel are missing in their programs.
Yeah, it's kind of like, why not? You might as well strengthen them, but also when you test hip flexion, it's pretty weak a lot of the time, or people aren't able to do it without like holding onto a table. So yeah, I've actually been doing that a lot more too, which is kind of interesting. But whether it's eccentric or not, or in range lift off, I like both of those ways. But eccentric can give you a little bit more mobility too.
Yeah, definitely. Anything else to add? Anything else?
No, I think that was pretty good. Again, that paper from Mike Reiman and Christian Thorborg is really good. There's a few others out there. If you really want to deep dive into hip pain and FAI, the April 2018 edition of JOSBT was kind of a special edition that has 10 to 15 papers in there, ranging from clinical commentary, systematic reviews, and case studies. So we relied on a lot of that in preparation for this episode too. So we can link that. We'll just link that paper or that issue in the show notes. But other than that, I think I'm good. Is there any other resources that you would use or that you did use for this episode?
Yeah, I relied heavily on that special edition issue of JOSPT. And then anything with Mike Reiman or Christian Thorborg. So you can look them up on like ResearchGate. They put a ton of great information about hip and groin pain, whether it be FAI, adductor strains, just hip related pain in general. Those are pretty much the two heavy hitters that I look to in terms of getting research for hip and groin pain.
Yeah. And also good principles that can be applied across the board in physical therapy. Yeah, I think you're good to close it out. Hopefully that was helpful.
Yeah, I definitely learned a lot going through this stuff, and we'll be able to post some exercises with how we think and how we like to treat. We'll put that up on Instagram eventually. So if you guys have any questions, make sure to reach out either on Instagram, email, on our website. If you have any questions or have topics that you want us to cover, just reach out and we'll be able to get that to you guys. All right, we can close it out.
Yep. Yeah. Thanks everybody for listening. See y'all later.
Yep. See ya. Thanks for listening to the Athletes Performance Podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website.